these are high numbers. And actually, we were hiding behind the numbers where the ratios which cannot tell cannot show you some of the value sites, but now we exceed the value sites. And these are big numbers. Why these are big? We have these big numbers despite of the utilization. The issue of quality, you could see, is featuring a lot from the antenatal, from the labor and delivery and postnatal. And I think that is the biggest again. How do we move forward in terms of making sure that the women attend in the health facilities? They attend these health facilities. They measure blood pressure. They check HB. They measure urine. And when they go to the labor rooms, they are monitored with pathograph and etc. Make sure that they get quality services. Possibly is our biggest challenge for the policymakers and for you in the room. How do we mitigate that challenge to make sure women and children receive quality services? That's the best approach.
Thank you very much, Dr. Mabwani. And I think that's really took us very well to the next speaker. If you may also add on that point, where do you see the role of the private sector as well as the NGOs? Very sad.
Thank you very much. Thank you very much for this opportunity. Again, with regard to the issue of quality, it's very hard to find out the quality. As per a lot of agenda, you can define quality by looking into 3 components. So looking into 3 components, that's the structure, the processes, and the outcome. So as far as the President's office is concerned, we have tried to look into the structural quality by investing into infrastructure development, human resource for health, and trying now also to engage the community to be part and parcel in improving the quality. Now we have already constructed the infrastructure, but that's not enough. We need to encourage the community to utilize services. So what we learned from the areas where they didn't have facilities, now there's an increase in service utilization. That's a good sign. And also there's an increase in institutional delivery. Prior to the initiative which started 3.5 years ago, we had a number of women who didn't have access to primary facilities for delivery, and for those who had a complication, they could hardly have the cesarean section. But after the centralization of services, whereby now we have the medical officers working at the health center level, which was not there before. Initially, these health centers were manned by assistant medical officers. Now we have the medical doctors. That has helped a lot. Now you could see from what Dr. Mabwani was presenting, the number is going up. So we are anxiously waiting for Tanzania demographic survey and census to see how much we've improved in terms of reducing the maternal mortalities and morbidities, and including, of course, the near misses. Apart from that, we have a number of partners, both the state and non-state partners. We have come up with information system which helps us to coordinate the partners. They were down portal. Of course, we are working together with the Register for Non-Government Organizations to see how we coordinate our partners. Because initially, you could see 3 or 4 partners working in one district council, implementing the family planning-related intervention. But as I'm speaking to you now, we have improved the amount, and that helps us to leverage resources instead of having 10 or 15 our partners working in one area while other areas are deprived. So coordination is quite very important. You can have very few resources. If they are well coordinated, then you can have maximum impact. So we believe with coordination at the President's office, together with millions of us, we shall be able really to reduce maternal mortalities, of course, and morbidities. But apart from that, what also we need to make sure that we improve, and then this is one of the biggest challenges, and see, I was looking for Dr. Sando. So he did, I think it was 2017 or 2016, he did a study looking into respective maternity care. And the data which we got from that study, which has been published, really it made us work up and try to see how best we can invest into that. Majority of women who delivers at the primary health care facilities, they complained that they do not receive the care and respect which they deserve. So now that's up to us as the government. So in the meantime, we are engaging different partners to see how are we going to invest into respective maternity care initiative so that to attract more women to deliver to healthcare facilities and to utilize the services after the construction of these massive primary health facilities. Thank you.
Asante sana Dr. Ntuli. A round of applause to Dr. Manyani and Dr. Ntuli. And I think from Dr. Ntuli's point, leveraging, because for me resources are minimal, but if well utilized, they can yield a very big impact. And I think here we're also talking about both the supply side and the demand side. And again, the respect for maternity care, because that's what will attract more women to come. Because again, non-utilization also is a part of indication of poor quality services. And with that, I would like to welcome Dr. Mohan, who can also now talk from his experiences. We've seen you have a very extensive experience.
As a country, we have done very well when it comes to overall under 5 mortality reduction. We seem not to perform equally fast enough when it comes to maternal and newborn death reduction. Now, for the maternal, there are 3 important interventions. That is family planning, skilled delivery attendance, and emergency obstetric care. I will come briefly now discussing each one of them if time allows. And when we come to newborn, we have essential newborn care, which when implemented universally and at high quality, it's known that it can reduce newborn death up to 71%. That's a high number. And what are these? These includes simple interventions that is called care, ensuring that babies born with breathing difficulties are resuscitated, thermal care, and ensuring that these newborns are breastfed. Now, with that, as a country, what have we done? For skilled delivery attendants, we have tried to train people so that they have the right skills. And this is included in-class training, mentorship and coaching. The question is, with all those efforts, have we been able really effectively to impart the skills we wished into the hands, hearts, and the brains of these service providers? I think it's a question for all of us to know. As we see more and more women are delivering in health facilities, but we don't see proportionately the reduction in maternal and newborn deaths. The government, as Dr. Ntuli said, is trying to employ more providers to ensure that the number is also addressed. As a country, we said in the morning, we may be having about half of the health workforce we need. As a country, we have tried to establish some quality improvement measures to ensure that quality is core. These have included measures such as establishing quality improvement structures across all levels of service provision and service supervision. On the other hand, how effective are these structures? You have quality work improvement team at the facility level, quality improvement teams, and now the ministry is rolling out structures at council and the RHMT level. How effective are these structures to oversee quality to ensure survival of our mothers and newborn? One issue pertinent is also having the required commodities and equipment to ensure that women and our newborns are served very well. And with that, we have established some mechanisms in the country, including ELMS, electronic management systems, and R&R for facilities which cannot order things electronically. how effective have we been? Because I come now largely in the area of family planning. Stockouts is not uncommon in our system. And before time bars me, let me talk on accountability and governance. We have structures, systemic structures, such as you have the RHMT, CTMT, S-Facility Governing Committee, and other systemic structures such as MPDCR. How effective are we using them? And on top of that, engagement of other sectors. You cannot say you will reduce maternal newborn death solely depending on the Ministry of Health or your right. We need other actors to come in a district, the district commissioner, at the regional level, the regional commissioner, the regional administrative secretary. How are they involved to ensure that resources are adequately put aside for the maternal and newborn health services? I think I have more to say. I should stop there. Thank you very much for listening.
Thank you very much, Dr. Marcos. Yeah, I think the key thing that I'm taking from you is effectiveness of everyone and all initiatives that we are putting in place. How are we involving everyone? It's not just a role of a healthcare provider, but it's also a role of with compassion. You also have to, feel a pinch whenever a newborn dies or whenever a woman dies, and that to motivate you for a change. And with that, I think I should now go to Brenda from CCBRT. And I think we all know CCBRT, and for long it has been working with the social inclusion of people with vulnerable population, including people with disability. So first, I would like to hear from you. Where do you think we are as a country in preparedness to serve people with disability?
The government. In terms of quality, Dr. Ntuli talked about structure, process, and outcome. And one of the things I think I'm an eyewitness of the transformation that we see in Dar es Salaam especially. The last 5 years have been phenomenal in terms of the infrastructure. It's completely different, and I think we have sown the seed that in the next 5 years, we're going to, if we do the right thing, it's going to be phenomenal. But one of the things, and then we also had another definition of quality that Alice talked about, which was competency, doing the right thing, the skills, as well as the experience of care, which is the respect for care. But the other aspect that I bring to the table through my organization is leaving no one behind. And that is about people with disability. And people with disability, that's the core business of CCBRT. So we address this through, I think, 4 pillars. One is life transforming, providing transformative, life-changing surgery for people with impairments like fistula, cleft lip, clubfoot, and enabling them to avoid disability so that they can now be integrated back into society and become economic and independent. The other area is we have a very strong advocacy unit where we advocate for rights of people with disability. Because people with disability are, as Frederick, our advocate, likes to say, they're not people with disability because of a physical reason. The disability comes from an unconducive infrastructure that makes them feel less than full citizens of the country. So what CCBRT has done, it has worked with the government to ensure that the voice of people with disability is heard. It has enabled people with disability to participate in the last 2 elections. And it's promoting the employability. So there's training of people with disability. We're still facing a challenge. So we use this opportunity when I have a mic. Would organizations strive to have at least 3% of their workforce people with disability? Because we need to engage them. They are willing, they're active, they're hardworking, and we need to be able to allow them to afford the health care we want them to purchase. The other aspect we have is a private wing that is part of our sustainability, where we have private services to subsidize the free services, because people with disability and women with fistula, they're about the most vulnerable people, and they almost will not have any money to pay for their services. So we have a private wing. But the 4th area that we deal with, which is the area closest to my heart, is the maternal and newborn health program. And we have a 2-pronged approach. One, we've worked with the local government for the last 10 years to support 22 public health facilities, and this year we've expanded to another 20. And this 20 has been done actually with government funds, where we have play a no-funding technical assistance role. So it's a great testimony to uptake and sustainability. The other point is we are building a 20-bed maternity hospital that is specifically designed to address the gaps, some of the high risk, the overflow, as you know, from the crowded maternities, as well as our target population is pregnant women with disability, women with fistula who get pregnant, and adolescents. And this brings us to the next question is, these are three very vulnerable groups that are not, that somehow face some stigma in overcrowded public facilities. So one of the challenges we're noticing with the public facilities is they're catering for people who can pay. So the idea the most vulnerable lack agency to get the care that they deserve. So really here again is another pitch for people who are most vulnerable. And during the process of implementing, we try to look for people with disability. And again, we notice there's no data. So that is another challenge. There's very few indicators for people with disability. We try to find out what kind of care they have, and we found that they don't like the private sector. They don't like delivering in facilities. And through our CSO partners, we organize focus group discussions and kind of found out what are the challenges. And they face three main kinds of challenges. One is the infrastructure is not conducive, the toilets, the ramps. Second is there's an attitudinal gap. So it appears that healthcare providers are surprised that people with disabilities have sexual reproductive rights and needs and have childbearing rights and needs. And as a country, we are lagging behind because health information material is not there for people who are deaf and for the blind. So that is again an informational gap, and our healthcare providers have not been taught how to address this. And I am responsible because in the medical school, we missed this module. So it's something that we have to make amends and start working towards. Through the program, we have developed materials. Health education in sign language, we've got sign language materials in Braille, and we're now working with Gender Health to develop the similar materials for family planning. So actually, women who are deaf do not receive any health information. So that is a serious infringement on their rights. And we are noticing this in Dar es Salaam, and the question I'm asking, what about the other regions? What about the 184 councils? Could this be a question that is asked, and not as an afterthought? The question I would like people to ask is, what about people with disability? So when we are planning insurance, we ask, what about people with disability? When we are planning new infrastructure, we ask, what about people with disabilities? When we are doing the next census, we ask, what about people with disability? And it would be good for them to be represented, even on forums like this, because they have a voice. So, in terms of the private sector, as a private sector, we're trying our best, but we do face a bit of challenge because of the cost of health. The cost is very difficult, and what we're looking at is that right now the mindset of the people in Tanzania is they're using the public infrastructure, and they're accessing services in the public sector. Only 10% use the private sector. So we still have work to do in changing the mindset of the population that those who can pay should use the private sector so that the public can be left to people who are truly vulnerable. Thank you.
Thank you very much. Yeah, and I think you've left us all with questions to reflect on, like how much is our programming inclusive of people with disability, and how are we going to program if we really do not have the information, the right information about the need that is there. And I think that also takes us to Dr. Isa. We've the rural and urban, but also different demographics. Very important place.
Thank you. Thanks a lot, Director, and I'm very honored to have the opportunity to be able to sit with these gurus in maternal health. I'm not a very guru in maternal health, but yeah, we are supporting and been providing oversight to a number of maternal health programs in Tanzania, and also that includes also designing programs which are responding to the needs of the country. So as AMREF, when we do programming, which is one thing we want to focus, of course, we understand that a huge geographical part in Tanzania. 80% of Tanzania women, they live in rural area. And AMREF, our main goal is really to reach to reach communities where they are hard to reach, where they don't access services. We are actually advocating for universal health coverage, and we always think about this population or community where we have where they cannot access care, and specifically women and children. So in our programming, we look at two things, or two main areas. One is the supply side and the demand side. Today we discussed very well with Ntuli and Dr. Makwani. And mainly, most of our maternal health programs, they've been focusing, or they've been actually implemented in the rural areas of Tanzania. We do not have urban maternal health like CCBRT, because we believe there's a lot of opportunities that already people live in the urban that get. So we always think of those in the rural areas as marginalized groups, which is here. So on the supply side, and I will echo what Moke was saying, we look at those issues of ensuring competency of healthcare providers. First of all, we mainly focus on designing programs that will build capacity, training of healthcare providers and facility. And also we look at improving infrastructure. We've done a lot in the Lake Zone and Simiyu, Geita. We have constructed theaters, labor wards, etc. In collaboration with the local government authorities there to make sure that the health centers, there are some wards, districts, they do not have health centers. Some wards, they do not have, and they are highly populated in the Lake Zone and the central Tanzania part. So in those areas, like last year, we constructed some theaters. This year, we are actually now winding up constructing almost 18 labor wards and some of them theaters, etc. Maternal health in 18 dispensaries, and Simiyu where they do not have this maternal health in the dispensary. So those kind of infrastructure. So we also look at strengthening governance, and this is the area that we find very, very useful. Empowering the governance body at the facility, but also at district level, training them on accountability, financing, planning, budgeting, reporting. We have very robust programs on that, just focusing on that. We have one called Model System Advocacy, where we have actually trained community, facility to kind of be able to account for reproductive health, like family planning, commodities, budgeting, prioritizing maternal commodities in their budgets, etc. So that's on the supply side, and that includes also strengthening supervision, etc., and making sure that the services are being monitored and there is capacity to do that. And then on demand side, now this is really our flagship when community demand for services, understanding first of all the benefits of the services, and we have strongly built the community structures, community health structures, and we've been advocating for community health structures to be revived, using community health workers to kind of promote and emphasize on antenatal visits. We have even seen data when I looked at yesterday on the data from different regions where we are actually doing our interventions. You can see this increased antenatal visits, increased institutional deliveries, etc. in those areas. So we are glad that these things are now. And of course, this network of community health workers, not only that, we have also tried to strengthen community structure, village health committees, ward committees, to understand and be able to supervise the community health program, which also focus on maternal health improvement. Yes.
Thank you very much, Dr. Isa. I think you said a very important thing, which was also stressed by Dr. Ntuli earlier, that strong governance is key. So wherever a person is, whether it's rural or urban, if the person who is in charge has governance skills, then things will happen. Dr. Talia, after you've heard from the speakers and as in charge of the quality assurance of the ministry, we'd like to also hear from you. Like, how are you now coordinating and ensuring all the quality improvement structure that exists is actually translated in different departments of the ministry, of partners, and all that? Very sad.
Thank you. I'm supposed to say all that in 5 minutes.
Yes.
So, as she said, I'm more on the policy part, where the quality assurance. And as quality assurance and improvement, of course, one of the challenges that we face is also working across programs and departments. Because here we're looking at about RNCH, but of course, quality assurance is cross-cutting. We have to look at TB, HIV, malaria. What can we do across all these departments and areas to make sure that the services eventually provided at the health facility are of the quality that we need? So maybe I can talk about the quality improvement strategic framework for the next 5 years, where the nature of repeating what most of the speakers have already talked about. We are looking at first the governance structures. So we have governance structures in QI, which have been developed in the first few years, but we want to strengthen these governance structures. So from the national level, we want to have a national QI committee. What we have now on the health facilities is a quality improvement team, but we seem to find that at the higher levels, we don't have the same level of QI governance. So at the regional and the council level, as Moki had pointed out, we are also trying to start to have the QI committees, where the various focal persons working in the vertical programs, but those concerned with data use, RNCH, etc., will work together to make sure we have effective and efficient use of resources, where they can share the QI experiences to make sure at the end of the day we have effective management of resources, but use of QI methodology to improve services at the health facility. But secondly, we need to have standards of care. When you're talking about QI, we have to have adherence to standards. This is what good quality care is all about. So in the RNCH, we are working with the RNCH department to adopt the WHO quality of care standards, which have been launched 2 years ago, to use them at the local context so that the health facilities will have quality of care standards in RNCH that they will be able to adhere to. But then also we have, how do we monitor that they're actually adhering to the standards? So we have decided to also start the clinical audit. So far, auditing is sort of a new thing in Tanzania. We are doing audits of deaths, the maternal mortality audits, but we need to audit more than deaths. We need to audit the processes of care. So we have a clinical audit guideline which should be signed soon and disseminated so that clinical audits can start being carried out in the health facilities. But after auditing for care, we also need to look at the client-centered care. How do we make sure the clients are receiving the care that they need? And here we have developed a client charter for health facilities. We're trying to get all the councils to develop a client charter based on the national health facility client charter, but also looking at the local needs. Every council will have needs that might be slightly different from other councils. We have disabled people that have their own specific needs, which are covered also in the client charter, but to make sure all the clients know their rights, know their responsibilities, and that these are adhered to. We're also looking at complaint management. We don't have a comprehensive standardized complaint management system. So we have developed the complaints, we call it the complaint complement and suggestion management guideline to make sure that we have really stable complaint management systems at the health facility so that we don't have the complaints coming out at the ministry level. We have the PS coming out with complaints, the Ministry of Health. Every health facility should have a good complaint management system in order to improve. But maybe what I haven't covered is the QI competencies. Over the past few years, we've been trying to advocate quality improvement into something new. And we have the QI focal persons who have been chosen at the council and facility level. We have the quality improvement teams. Do they have the QI competencies needed to carry out, to do the quality improvement? Why do we have a lot of facility deliveries but don't have an improvement in care? So they need to use the QI competencies, use the data available. That's another problem we have. effective use of data at the health facility level, leave alone the national level. At the health facility level, they need to use the data available to them to make sure they improve. And they need to be trained. We have developed also a quality improvement training package. They need to be trained to be able to do the QI methodologies to improve the services. Thank you.
Thank you very much, Dr. Salome. I think we've left us 3 questions to reflect. So one, yes, we do have quality improvement teams, but do they have the right competencies to really be a quality improvement team? But again, I think it's been a process, the usual process of auditing there, but maybe we are auditing when it's too late. We should start auditing the processes to prevent the death. So without further ado, I would like now to welcome the audience.